welcome back. This is Antibiotics and Overview Part 2. Just in the bottom there, I wrote it out for you so you just kind of know which antibiotics we'll be talking about today. So it's aminoglycosides, vancomycin, glycopeptide basically, tetracyclines, fluoroquinolones, macrolides, and lincosamides. Couldn't fit all of them into it again. There is a lot of antibiotics, but for Part 3, I think there's only a few left, and I think I might just include some like mnemonics and stuff to help with like everything in general. But yeah, let's get right into it. So this is just a slide that goes over the targets, which I had from part one. I figured it just helps give you a visual of what kind of bacteria to expect. So you can just kind of come back to this part if you were trying to remember which bacteria that it was, um, like what would be an example of a gram positive or gram negative, for example. And then again, I'm not going to go too much in the MOA. It's just going to be about high yield indications, adverse drug reactions, and then maybe other special things you might need to know about the drugs. Um, this time I kind of switched it up for you guys. So I kind of put little symbols, which talks about the adverse effects. So here we kind of have the kidneys and the ears. So that's going to indicate nephrotoxicity and autotoxicity, for example. So aminoglycosides, we've got gentamicin, tobramycin, amikomycin, neomycin, streptomycin. Honestly, you'll probably run more into gentamicin and tobramycin the most. Tobramycin you'll probably see more as like an eye drop, um, usually commonly used to treat conjunctivitis. And then gentamicin you might see more endocarditis. So one way to remember this, shout out to Cram the Pants again. He has very good mnemonics. I highly recommend checking out his channel as well. He goes more over physician assistance criteria. But anyways, so coverage includes pretty much all your gram negatives, including Pseudomonas, which is important to know. So you'll often see they're used for their synergistic effect in endocarditis. So you'll gentamicin especially you'll see that in mainly in endocarditis, and for some gram-positive infections. Now, some adverse drug reactions, as I just mentioned earlier, was the autotoxicity and nephrotoxicity. In most cases, the damages will most likely be reversible once you stop it. So there's another mnemonic. Again, shout out to Cram the Pants. Um, Sin, which is equal to crushes the incus for the ear, and nephrons for the kidneys. So trow monitoring is preferred for extended interval dosing, while peak trow is for multiple daily dosing. Um, this is just a kind of like a side note that you just kind of have to know for the PBAC exams for any pharmacy students out there. And then generally you want to hold gentamicin if the creatine clearance is less than 50 mils per minute, which obviously makes sense because of the nephrotoxicity as just described earlier. Okay, so now we got our glycopeptides, and then this one will be a big one because you got the king here, vancomycin. This is essentially your nuclear option, and the reason for it being the nuclear option is because of its effect on MRSA. So it has very good gram-positive coverage. Whenever you see IV dosing, you're obviously going to associate that with MRSA. Whenever you see PO dosing, you're going to associate with that Clostridium difficile infection, and it's usually a 10-day dose for Clostridium difficile. And the reason we use PO dosing over Clostridium difficile is that the way vancomycin works is it's not intestinally absorbed into the bloodstream, so it targets specifically in the intestines, which makes it great for hitting an infection like C. difficile, which is localized to the intestines. Now you do also get some gram-negative coverage like Neisseria, um, and just another note is you can also give the IV formulation orally as well. I think it makes it more palatable because the PO version, the tablets have a very bitter taste. Okay, so you do need to know the loading doses with this one, and you also need to know trial monitoring. So the IV loading dose is about 25 to 30 milligrams per kilograms. For maintenance, you need to monitor the trial levels at least 30 minutes before you administer the next dose, and you want to obtain a trial level of about 10 to 20 milligrams per liter. Now remember, trial levels is a way of seeing how effective the drug is, and then peak levels are associated with basically your toxic levels of the drug. So you always kind of want your drug just to be in between, because the reason for this is when we hit those high levels, so around the 15, 20 milligrams per liter, for example, now you do get nephrotoxicity, but this one is usually reserved for the extreme cases, such as MRSA, which is methicillin-resistant Staphylococcus aureus. Um, you also want to adjust the dose based on actual weight, not the ideal body weight. Okay, so some adverse drug reactions is something known as red man syndrome. The name I think has changed a lot now. Some people call it vancomycin infusion reaction, for example. Very rarely you hear red man syndrome, but essentially the symptoms are the same. You're going to get a very large rash that is widespread over the body, and your first instinct to say is, oh, it's an allergic reaction to vancomycin. It's not an allergic reaction, it's just an infusion reaction. So this can be avoided by a slow infusion, and generally it will resolve on its own as well. You can also use the mnemonic that we used for the aminoglycosides earlier. So crushes incus and nephrons. So autotoxicity and nephrotoxicity is big with this one. Um, Nephrotoxicity will become more prominent when you give it with other medications that affect the kidneys, notably loop diuretics, contrast dyes, and amphotericin B. Autotoxicity increases with um, hearing impaired patients as well. And then for your oral dosing, you'll get the classic nausea, vomiting, diarrhea, and then abdominal pain and the rare case of stomatitis as well. Also, it's important to note that this medication is safe in pregnancy, but PK may be affected. In renal sufficiency, protein binding is also reduced as well. Okay, this is your tetracyclines. Doxycycline is going to be your pretty much your star player in this class, but you may run into tetracycline and minocycline as well. Minocycline you might see more for acne. Coverage includes gram-positive, gram-negatives, MRSA, atypicals, and this is pretty much the important one. You'll pretty much only see this class like for odd treatment, like anthrax or Lyme disease, mainly. That is not to say you won't see it in the other ones, but it will still work. And just to note that it also works against MRSA as well. Oh shit. Let me just erase that. There we go. Doxycycline indications. So you'll see this for chlamydia, Rocky Mountain spotted fever, Lyme disease. Just an important note for Lyme disease is you can give it in under 8-year-olds, and this is due to that duration being less than 21 days for treatment. But generally, you want to avoid in other cases, and you also might see it used for acne as well. Same with minocycline as well. It does cause teeth gut discoloration and affects bone growth in children, so that's why we want to avoid it in at least under 8 years old when their body's still developing. It also chelates with antacids, and it can also cause something called esophagitis. So when you counsel a patient, you want to tell them to take this medication with a glass of water and remain upright for 30 minutes after taking the dose as well. Um, Sensitivity, it does cause photosensitivity, and you want to use the slip, slap, slop, seek, slide. If you don't know what that is, it's used in Australia. Basically, what it means is, you want to slip on a shirt, slap on a hat, slap on some sunscreen, seek shade, and put on your slides, which is basically your shades. Minocycline can also cause a rare side effect called drug-induced lupus and hepatic cholestasis, but honestly, I would just remember the drug-induced lupus. And then you need to adjust the dose in renal impairment as it can increase it can increase urea levels. And then also generally these medications you want to avoid in pregnancy. So as you see here, the teeth discoloration and esophagitis, the sun, and pregnant women. Okay, fluoroquinolones. There's I think the best way to explain fluoroquinolones is like it's basically separated into subclasses, which is respiratory quinolones and urinary fluoroquinolones. And it's just exactly how the name says. Respiratories are going to more localized to basically like lung infections, so pneumonia, for example, and then urinary is obviously down below. Generally, you want to reserve these for more complicated infections due to ADRs, and you can see that we've got like almost 4 important ones here, which I'm going to go over. An also important thing is they cover Pseudomonas, which is great. So moxifloxacin has the best gram-positive coverage, atypicals, and anaerobes, but doesn't have any urine activity. Levofloxacin, same thing, but it does have a little bit of urine activity. And then ciprofloxacin has probably the best gram-negative coverage because of its lowest minimum inhibitory concentration, which makes it the best one for Pseudomonas infections. It's also good for UTI and pyelonephritis. And you can kind of remember this with the only fluoroquinoline with P in its name. So you can kind of remember that it's the best one for pyelonephritis and UTIs. So indications that you can use these for, so pyelonephritis, complicated UTIs, prostatitis, and community-acquired pneumonia, including pseudomonas. So just to note, moxifloxacin will only be seen pretty much in community-acquired pneumonia, even rarely in that as well. You probably won't even see it that much. And generally, you want to avoid this in pregnancy. And I said children to 16 to 18 years because it sort of varies between places. In Australia, I think they say 16. In Canada, I think they say 18 in certain places and 16 in other places. So, yeah, it's because of the tendinopathy, which is the side effect with it. So, tendinopathy, as I just mentioned there, and then you got the QT prolongation as well, which is a very, very important side effect. So you want to be careful when you're taking other medications. And so what you'll usually say on like the vignette that they'll give you in the exams is they're going to give you a patient with all these medications, and you're going to notice that um, they're not going to say it outright, but then you have to notice that, oh, I can't give them this because that patient's on methadone, and that's going to cause QT prolongation, for example. So you'll have to be mindful of that as well. It can participate in something called myasthenic crisis. So you want to avoid that in myasthenia gravis. And it also causes some C. difficile diarrhea, constipation, photosensitivity. It also chelates with acid, so you need to take it 2 hours before and after. Also, I forgot to mention that for the tetracyclines as well. So you want to take it at least 2 hours before or after with antacids, and if you can, and take it on an empty stomach as well. There's also CYP interactions, so they are a CYP1 and 2, 1A2 inhibitor. And I kind of wanted to just keep this as a side note because obviously sometimes I always forget about this one. Cigarettes induce CYP1A and 2, so they're a CYP inducer. Ciprofloxacin and ciprofloxacin, levofloxacin, moxifloxacin are 1A and 2 inhibitors. So I think the main thing I would take away from this is it causes QT prolongation, photosensitivity, avoiding pregnancy, and then that CYP1A2 interaction. But it's very rare you'll see CYP1A2 interactions. Probably like with coffee at most. Okay, we got macrolides. So the ones from this class are azithromycin, clarithromycin, and erythromycin. Typically, it's gram-positive and negative coverage, and atypicals. Azithromycin, you'll probably see the most for atypical things. So atypicals, like I said earlier, they're more like pneumonia infections. So indications, you got chlamydia, azithromycin you might see in traveler's diarrhea as well. MAC, Mycobacterium avium complex, and a way you can remember that, MAC and macrolides. And then, like I said, community-acquired pneumonia, and perfect, it covers Pseudomonas, which has a lot of resistance to a lot of antibiotics. And I know it seems like, well, you've mentioned Pseudomonas a couple times, but trust me, those are only just a few that actually work on it. Gastroparesis, azithromycin actually increases the gastric motility, so that's good for treating that. And also COPD bacterial exasperations as well. Azithromycin will be the popular one for that one. They're all safe in pregnancy except this one, erythromycin estolate. Now, erythromycin, like any other salt of erythromycin, is safe. It's just the estolate salt. So that's why I'm putting it here that all other salt forms are okay for erythromycin, just the estolate. So erythromycin is safe, just not the estolate form. Some adverse drug reactions are QT prolongations, some prominent GI side effects, especially erythromycin, and then some hepatotoxicity and cholecystitis. Now, I think the one thing you should note that's most importantly is they are CYP inhibitors, but clarithromycin is probably the biggest one. It's a big CYP3A14 inhibitor, and you'll always see this somewhere in the exam that a patient is on this. And as soon as you see clarithromycin, you're like, okay, there's a CYP interaction somewhere. So that's like your biggest hint. Otherwise, you won't generally see clarithromycin. I can't even think of like an indication off the top of my head that you might use it over azithromycin or something. But clarithromycin, whenever you see that, just think CYP inhibition. Okay, and then this will be the last one, which is Lincosamides. Not too much to say about this one. It's clindamycin. Don't confuse it for a macrolide. A lot of people seem to do that. They confuse it because I guess they see the myosin, so they confuse it for a macrolide, but it's its own class. It's not a macrolide, so it's not going to cause that QT prolongation, for example. So don't get those two mixed up. It's got good anaerobe and gram-positive coverage. In terms of indication, the only time you're probably going to see it is when someone has a penicillin allergy and we just need to give them an alternate medication. And now when I say penicillin allergy, I mean when it's like a life-threatening allergy, like anaphylaxis. So this is pretty much reserved for that kind of indication. Otherwise, you might see it in some acne treatment, usually as a topical. Now, this is probably the most important side effect is diarrhea, especially C. difficile. Out of all the antibiotics, this one has the highest risk of causing C. difficile diarrhea. It also can cause a skin rash as well. It's also a substrate, so it is affected by CYP inhibition and CYP induction. Okay, so that's pretty much it for the part two. I'll probably release the part three maybe sometime this week or maybe this weekend, who knows. And then for that one, I think what I'll do is I'll probably talk about two more major antibiotic classes, and then from there, I'm just probably gonna include some little tips and tricks, mnemonics to kind of help um, to how to kind of help you remember like certain antibiotics and everything. But yeah, um, yeah, but just let me know if maybe there's other things you want me to go over or anything. And yeah, because this also helps me learn too. Perfect. Thank you guys. Good luck on your exams.